Today what I'm going to talk about is basically using data to drive the length of stay in a ER. This might be applicable to any hospitals, but I'm going to go through one of the projects which we did for a hospital and basically walk you through how we went about doing it and what was the results from the study and how the hospital went about implementing some of the changes. So a hospital kind of approached us to look into to look into the length of stay of patients in their ER. Their goal was currently the length of stay was much greater than what the standard length of stay for a patient was in an ER. So they wanted to see what can be done to reduce the length of stay in the ER. And we are looking at the process where a patient has once he's done with all the ER formalities and the ER formalities, and he's basically either gets discharged or get admitted into the hospital. That's where they thought that the patients were staying on for a much longer period of time than they were supposed to, because every patient who stays in ER for longer than what he's supposed to stay will basically eat up more resources. As you know, the nurse to patient ratio in ER is pretty high. That means for every one nurse, there'll be two patients. So if a patient who's now clinically okay to be discharged or okay to be sent to a admitted room has to be quickly gone to the next stage. So the hospital thought the patients were not flowing out from the ER as quickly as possible. That way, kind of tying up the nurses in the ER with the patients who were clinically okay. So as you see in this patient flow, we went through the process there. Now the ER patient arrival, then you have a decision to admit or no care completed. So the physicians have to make a decision where, hey, this patient now has to be admitted for further observation, or or the physicians say, hey, this patient is okay for now. He can go home. So that's a one big delay there. So once the time the decision has been made, there's some delay there because a nurse has to come there, make a call to admissions or get the paperwork done. In case the patient has to get admitted into the hospital, the nurse has to call the admission room, make a reservation into the bed, assign a bed. Then once a bed has been assigned to a particular patient, a report has to be given. Report is very similar, kind of giving a history of what the patient came in for, when he came in, what happened, kind of thing. Once the report is given to the respective RN at that admitted level, then a request for transportation is called in. So once the request is made, again there might be a delay. Then that's when the patient departs from the ER and gets admitted into an admission room to any of the admitted floors. So this is kind of a flow, and this is based on this particular hospital. This was the process they were following. And as you can see, there's a lot of delays in between each of these processes. I mean, the delays might happen because of several reasons. That's where we will get into more details. And we want to see, hey, why is this delay? Why is where is the most delay happening in this whole process? So as you can see, there are a few upstream process and the downstream process, and we kind of need to look at what is the constraint, what is causing the most delays to most patients in this flow. So again, we went about collecting data. We looked at we looked at the ER length of stay, and you can see as I mentioned to you, the target length of stay for ER was 6 hours, but the length of stay for weekdays was close to 7.7 hours, and length of stay during the weekend was close to target, but it's still on the higher side, a little higher than the target. So the hospital wanted to see what can be done to improve this process. All right, so what we did was we went about collecting some data. we looked at the process flow. We looked at the process flow. We understood the process flow. I mean, that's the basic of before we get into any project. Understand the process flow and get a grasp on what are the things that are supposed to happen. So as you can see that, remember from the previous slide, we were showing you about different delays happening in between the processes. So we were trying to capture all the delays happening there. So the first delay is a decision to admit to request a bed. So there was a 55 minutes delay for making a request to a bed. That's after the physician has made a decision to admit the patient. So it takes 55 minutes from the time a physician makes a decision to admit a patient. So that was, I would say, on a little higher side. And now as you can see, the next delay was not that much. It was just 7 minutes making a request in the bedboard system. But the biggest delay in this whole process was assigning a room. It was taking close to 103 minutes. And there are several factors why it would take to assign a bed to a patient. Now, again, we'll walk you through that. Again, so these are the delays we collected for different patients. As you can see in the table down, the last row is basically number of patients, data we collected for number of patients. And also the total time to give a report, which is as simple as now calling the respective RN at that particular floor and just giving a report, which takes only 2 or 3 minutes. This was causing 55 minutes delay, which is supposed to take 1 or 2 minutes. Again, different constraints during the weekdays and the weekends. Again, we kind of categorize this data based on weekdays and weekends. As you can see, during the weekdays, getting a room assigned was the biggest constraint, whereas in weekdays, making a request for bed after the care was completed was the constraint. So as you can see, we looked at the biggest constraint, that is during the weekday, request for bed board to be assigned to a particular patient. One of the key constraint was bed not available. So basically, there were no beds in the hospital for the patient to be assigned. So that was causing one of the delays for bed not being assigned. And the other two were room assigned to a bedboard. So there were a couple of systems there they were using. A room was assigned, but the RN in the ER couldn't see an assignment, a room assignment for the patient in a software called MedHost. So only when the patient was able to see, when an RN can see a room assignment number or a room number assigned to the patient could be released from the ER. But again, there were some delays in the room assigned on the bed board, and which is not reflected in the MedHost system. Again, sometimes ER clerks, as you say, they're very busy in the ER, and sometimes they were immediately not being notified, or they were not checking the systems to see whether the patient was admitted, was assigned a bed. So that was those were the three biggest constraints there, or I would say three constraints there, why the delay was happening for a bed assignment for a patient. So again, based on ER delay by bed type, and there are different classifications for a bed type. And we collected data on which type of bed type was causing the most delay. So again, this is kind of looking at breaking down the constraint to different areas and dissecting it which is causing the most delays. As I said earlier, which is causing the most delays to most patients. As you can see, the last three, the SICU, the tele, and the tele-obs, was causing the most delays, most overall delays for the bed. Again, what we had to do is initially we had to go back. I would not say go back, and we had to look into the process flow and see how a bed request was made. How was this kind of translated into assigning a bed for a patient? So there are number of steps involved from the time a nurse makes a request for a bed for a patient. So there are different process steps involved. So we had to take a note of all these and look into all the delays happening in each of the process. So again, as I mentioned to you, the primary nurse calls the registration for patient information for bed request. Registration is manually noted down. There was one bed czar who kind of is monitoring all the beds available in all the floors. Once the bed czar makes the bed for the patient, gets the bed in a particular match the patient, the bed is assigned. Then again, the registration also is looking at which bed number is assigned to the patient. Then the ER nurse has to be notified about the bed assignment. Again, this requires basically this whole process requires multiple phone calls to request a bed and of course to obtain a bed assignments. And handoff also created some additional work and opportunities for delays. Again, continuous monitoring leads to delays. I mean, if someone has to continuously monitor this was also kind of causing delays in the process. We were breaking again each of the delays into why such things happening. And one of the things we looked at is delays in attempting to make a report. That's when a bed is assigned to a patient. The ER nurse has been notified a bed is available for a patient. Then she has to give a report to the respective RN at that floor. Again, there was a delay of close to 35 minutes there. And we're looking at why is this delay there? There are a couple of reasons for delay. One is the ER nurse is not available to give the report. From the time the bed has been assigned to a patient, the time the clock starts, right? For 26% of the time, the RN nurse were not available to give the report. But that's because ER, as you know, is the most busiest of all in the hospitals, and they were busy doing something else. And the other thing is, okay, even once the report is given, there are not the report is given, but the other reasons where there were special requirements, kind of the nurse procedures had to be followed. It might be warmer blanket, pacer pads or something like that. That was again causing the delays. And sometimes the admission unit nurse was busy, so the RN nurse called the respective RN at the admission unit, and that respective nurse was doing something else. That was the biggest reason for one of the biggest reason I can say, because it's making up to 41% of the time. The other reason was the ER shift change delay. So if this something happened during the shift change, then there is a delay there because the nurses don't want to accept a new patient during the shift changeover time, because if a new patient moves in to their floor during the shift changeover time, it requires more time for them for the RNs. It basically takes more RN time. Now they have to make sure the patient is okay there when he or she gets to the room. They have to take some vital statistics. Take the few of the tests they have to do when the patient moves into the room. So some of the nurses, they didn't want to take a patient during their shift change time. Again, we kind of recommended some of the actions to be considered. Then other thing we looked at is the admission unit process. So other thing we wanted to see is what is causing the delays in the admission unit process. So let's say the ER nurse was able to contact the RN at the respective floor, and she was able to give a report. She was given a report. So once the report is given, the admission unit completes the admission process for the patient. The report is given out. Then basically once it's done, the transporter is called. So the transporter has been called, and kind of they get paged and saying that, hey, pick so-and-so patient from so-and-so room and transport the patient to a certain particular room. That's when the patient departure has been recorded. So again, you can see the different data points on the delays in the admission unit 2. Giving a report was one of the things before the patient arrival. Again, we broke this data into looking at which is causing the most delays to most patients, and we were looking at the process flow, looking at the delays, handover, sometimes certain handover procedures. Again, we were for each process we were looking at what can be done with no cost improvements and kind of the medium cost improvements. Again, it was kind of a part of the project we were supposed to do. And again, there were inpatient floor processes. If you remember, the biggest constraint in the hospital, patient staying in the ER was, the beds were not available in the hospital. So then we had to go look deeper into that process and understand, what is happening there. So this is basically the inpatient floor process. So we started tabulating, process mapping. What happens when a physician in a particular room, not in the ER, but in one of those floors, writes a discharge order? What happens then? So these are the steps involved in the discharge process. As you can see, a lot of steps has to take place from the time a physician writes, "Hey, your patient, you're good to go. You're clinically fine. You have been discharged." All right. So as you can see, a lot of steps, and if you have this many steps, you are bound to have a lot of delays in the process. Again, we're looking at now from the time the patient discharged. So as you can see, discharge orders to start up paperwork. There's a 19-minute delay there. That's basically a physician writes, "Yep, this is so and so patient has been discharged." Writes a paper, and he has to give that he or she has to give that paperwork to the RN. And there is a 19-minute delay there from the time the RN receives the discharge paper. The RN might be doing something else, so she might take up that order later. Then the paperwork complete to patient out is close to 1 hour. That's basically he or she has to compile all the documentation for the discharging. So the next step is basically, once the patient leaves the room, based on the type of patient in the room, there are certain types of cleaning has to happen before the next new patient arrives into the room. So as you can see, the biggest delay was the housekeeping. The housekeeping kind of unfortunately was causing the delays in assigning the beds. So you can see close to you can say 2 hours plus I was cleaning up the patient room. The reasons for delay for cleaning the patient rooms, once the patient has discharged, the people were now cleaning other rooms. That was given more importance than the room which a patient got discharged. It's a couple of times this happened during the break and the lunchtime, and also sometimes the priority was given to another room. So the biggest reason with the kind of routine cleaning was causing some of the delays for cleaning up once the patient was cleaning the rooms where the patient was discharged. So we came up with some strategies there for improving the process to reduce the delays. And we were saying it should be a kind of a pit stop mentality. Now, as you know, in the racing world, now if a car kind of stops for whatever reason, now all of them attack the car, whatever. Now, you're refueling the gas, changing the tires, or taking care of anything. So this kind of mentality has to happen. And as soon as a patient gets discharge paper written, it has to attack in several ways. The physicians have to be quick enough to write the discharge paper, give it to the RN. RN should make that as a priority to get the paperwork ready and done. And once it's done, she has to let the cleaning team clean that room immediately to drop what they were doing in terms of the routine clean if they're doing. So again, that's something which that was lacking. The urgency was not there in any of those phases or in the processes. As you can see, from patient one leaves, there's a delay of 33 minutes. Patient one leaves the room, and there is a 33 minutes delay from the time the patient left the room. The house cleaning starts, then the house cleaning ends, and also when the house cleaning ends, there was 103 minutes delay from the time the house cleaning ends to the second patient arrives. Again, there was we'll go through why there's like close to I would say close to 3 hours of room downtime. I guess now in terms of if you're looking at this 3 hours is kind of non-value added, or it's not profitable for hospitals. So hospitals are profitable if all the rooms or all the hospital beds are occupied. But in this case, no, the 3 hours, close to 3 hours, a bed was not occupied by any patient. That means they can't bill for that period of time. So it's kind of a, I would say, loss to the hospital. So somewhere in the 103 minutes delay, a patient in the ER is assigned to a room number. And the patient, the ER, is transported to the unit. So this 103 minutes was more than what, close, I would say, no, 1.5 hours. That was, we felt that's too much. And we kind of did some other things, kind of looking at, hey, what if you reduce your room downtime? Means if you reduce the 40-minute room downtime represents 47 more additional missions per year. So that, think about that. Now, you as I mentioned to you earlier, if for 3 hours you don't have any patient on the bed, that means you're losing revenue. So that's basically, that translates to that money, earning the extra money. Again, we looked at what was causing the delays, and kind of come up with a system to improve the process. Again, looking at the capacity, we came up with some opportunities there to let the hospital know what can be done. So the hospital were able to implement most of the changes, and they did see big difference, or a big, as you can say. So the ER is kind of, I would say, the first, I would say, department in the hospital where the patient come in, not all the patients, but no, the emergency patient. And the discharge which happens at the back end of the hospital was kind of causing the delays or the overstay of patients in the ER. This is something which it opened some of the eyes in the hospital, saying, wow, something which is happening in the back end is causing a big delay in the ER. So this was an eye opener for the people in the hospitals, and they made a big rush to make sure when a patient is discharged from one of the floors, the priority was given to make sure the patient leaves the room as quickly as possible. And once the patient leaves the room, again, there was importance given to make sure the room gets clean immediately, notified to the respective the bed czar, who is basically assigning the rooms to the patient in the ER, so that this the process happens without any delays anywhere.